to make pressure with others, with our colleagues, the activists. And we know, and HIV/AIDS has been, I think, one of the best examples, how much representative of patients can make the pressure on the government, can make the pressure on the private sector to reduce the price of the drug and to allow also the production of generic. So we have again to work all together to improve the health of others. We have in parallel to continue science. Because even today, 27 years after the discovery of HIV, still, you have seen, prevention, treatment are the priority. And we have new priorities also as well to treat. We have to consider co-infection by HIV and tuberculosis, co-infection of HIV and hepatitis B or hepatitis C, and so on. We know that in some countries, in particular low-income countries, when you treat patients and they have both TB, for example, and HIV, they are doing better for HIV infection, but they develop immune reconstitution syndrome. And some of them die of immune reconstitution syndrome. So that means that we have to improve our knowledge of co-infection and treatment of co-infection. We have to work, and I will say a word in a moment, on complication and long-term heart in patients. We have to work in order to have new therapeutic strategy and new vaccine strategy for tomorrow. And this will be based on a better knowledge on the establishment and persistence of HIV reservoir in the different compartments of the body. We also have to understand the very early mechanism during the acute phase of infection. I'm speaking about the first hours after exposure to the virus, the first 96 hours after infection. We know today that everything is decided very early, even if it is a slowly progressing disease. And we are far to know everything. We are far to understand the very early signals that are responsible for abnormal immune activation that is seen in HIV-infected individuals. We are far to understand the signals that the virus or components of the virus are able to abrogate or to alter the crosstalk between cells of innate immunity and cells of adaptive immunity. We have to understand better the mechanism of protection for which that a vaccine should induce. We don't know. We should be frank, we don't know which kind of response a vaccine should induce to be effective. We had to understand better, we did already a lot, but we had to understand better the interaction between viral factor and cellular partners at the level of the cells in order to develop new molecules to stop those interactions. After more than 2 decades, there is still gaps in HIV treatment and gaps also in equity. Indeed, we have today, let's say, more or less 2 profiles. We still have AIDS-associated morbidity in resource-limited setting because we still need to get the drug to all people that need it. We had another profile, which is a profile of rich or middle-income countries that is appearing. The non-AIDS-associated morbidity related, which is caused by high complications like resistance to drug, metabolic disorders, including cardiovascular injury, premature aging, cancer, that we are starting to see in a significant proportion on patients that are on long-term heart. We have to understand better the impact of the treatment toxicity together with the role of HIV itself in inducing a persistent inflammation that remains even on heart. We know that we don't have a full reconstitution of immune cell function. And we have to consider the lifestyle also in those complications. And lastly, of course, we are all dreaming about the eradication of HIV. I prefer to say, let's dream about a functional cure for HIV. We are not yet there, but there is a renewed effort that began already for at least reducing the size of the reservoir in different compartments of the body. So there is need still today for more mobilization and more research to develop new molecules and to make these molecules available for all. And we need to find solutions to have a functional cure of this infection. There are potential strategies are already ongoing for tests. The idea is, for example, to intensify antiretroviral treatment very early after infection in order to reduce the size of the reservoir. There is several clinical trials ongoing in the world on that aspect. The very early intense antiretroviral treatment was tried. The first clinical trial, to tell you the truth, were not so promising. We have tried already also to enhance anti-HIV immunity by using immunomodulating agents or even by vaccine therapy without any success up to now. That does not mean that we should stop, because like for vaccine, I think probably we did not try the best strategy, and we have to learn more about immune pathogenic process. We have new drug with improved penetration and patency that will be tested, as well as a new strategy to try to unlock the latency into HIV-infected cells. So it's ongoing, and we should remain optimistic for the future. What about prevention? Prevention, antiretroviral treatment today should be part of the prevention strategy as well. ARV might be used in pre-exposure prophylaxis or in post-exposure prophylaxis. There is several studies going on already in different countries in the world, clinical study to evaluate pre-exposure prophylaxis and post-exposure prophylaxis. The test and treat concept is also ongoing for trying to show that we should validate first this concept before application. However, we know already that antiretroviral treatment reduces the viral load in the level of the genital secretion, and it has been reported at a conference in February in San Francisco that when a partner is infected by HIV and on treatment, you have a reduction of more than 90% of the risk to infect the non-infected partner. So this is a very nice data in favor of the test and treat concept. Up to now, another means of prevention, microbicide, have not been successful at all. The non-specific microbicide like benzalkonium chloride, for example, those approach, non-specific approach, cannot work because they are too toxic. They create lesion, and even they increase sometimes the transmission of the virus. But we have today a new kind of approach, which I found personally very interesting, to use new specific microbicide. But in the microbicide, indeed, what do you have? Antiretroviral drug. And I think this is really an interesting approach. Again, study are ongoing. Circumcision. Circumcision, of course, circumcision not alone. Not alone, because we know that it can only reduce the transmission of between 50 and 60%. That's not enough alone. But associated to others, it might be something to consider. Vaccine, I will come on that point. Up to now, until the Thai RV 144 trial, it was a total failure of the classical approach, we must say. This is just to show you that the test and treat concept, we stop viral replication by ARV, we have undetectable viral load in blood, and very often in high frequency genital secretion. It was a model published at the end in the Lancet at the end of 2008, showing that if we apply this concept of universal voluntary HIV testing and immediate treatment in 2020, we will stop the HIV epidemic. Of course, it's a dream, because we all hope that we will arrive to this situation, but we know that it will not be so easy. So reducing the incidence of HIV-1 is today one of the major priorities in global response to HIV. And we have to combine for this priority of prevention all the different approaches: education, information, counseling, for improving behavioral changing, usage of condoms. We have to consider treatment. We have to consider biomedical strategy like circumcision and maybe others like specific microbicid in the future. But we have one component here that we have to keep in mind, which is today one of the major obstacles for the testing of HIV individual. We have today too much stigmatization, discrimination against HIV infected individual, and as a consequence, people don't go for the test. And this is really one key issue if we want to improve the proportion of patients that go for the test and will benefit earlier of the treatment in the future. HIV vaccine history, few words. It started in 1987 already with the first phase 1 trial. Very empiric approach since between 87 and 2007, more than 110 trials with about 67 products used as vaccine candidate in almost 30,000 human volunteers. What we could say at the beginning in the phase 1 to trial is that the vaccine were usually safe, and some of them were showing some immunogenicity, and we had to wait 2003 to have the first data of the first phase 3 efficacy trial by a vaccine candidate of vaccine, which was corresponding to the envelope of the virus, but the monomeric form of the envelope. And this trial clearly show a lack of efficacy of the recombinant, monomeric recombinant GP120. We had to wait 2007 to have the data of the second efficacy trial, called the STEP trial and the PAMBILI phase 2B trial, using as a candidate adenovirus type 5